Dr. Jason Porter from West Cancer Center. He's going to present on diagnostic standards for ruling out cancers.
So I am going to talk about diagnostic standards for ruling out cancer, but I'm going to be true to my cause, and that is lung cancer. And the reason I'm doing that is not to ignore the other tumors, but what you've seen and what you've heard tonight is a lot about breast cancer and a lot about colon cancer, and we know about prostate cancer screening. And so I'm going to go through that just really quickly because those things are very important. But when we look at the 5-year overall survival for patients with those tumors, it makes lung cancer, really look bad. And one of the reasons is the way we screen for lung cancer, the uptake of that lung cancer screening, and until we change the way we're doing it, because we're doing it wrong right now, until we change that, we are going to continue to see lung cancer at the bottom of the list, just like you see it here. It's always at the bottom of the list right now. And we got to change that, and there are a few ways that I recommend we do it, and I'm going to keep having this conversation. I've been having this conversation all over the country, and I'm not going to stop saying the things that I have to say about lung cancer, because until we do, we are going to see more and more people die from lung cancer, including never smokers. So 1 in 5 patients with lung cancer is not a smoker. So that is not a trivial number. That's 20%. That means if you're sitting at the table with 5, look across. One of you, even though you never smoked, could develop lung cancer. So we'll look at breast cancer, prostate, and colon cancer screening. Then we'll look at lung cancer, and then I'll just briefly touch on screening for at-risk populations. So I come up with this mnemonic that I like, and I'm going to start kind of pushing this out everywhere. It's SDMT. What's S? Is screening, diagnosis, molecular evaluation, and the T is for treatment. So screening, that's mammography, colonoscopy, PSAs for prostate cancer, and then now we're doing low-dose screening CTs for lung cancer. Diagnosis, after you have screened and you found an abnormality, whether it's in the colon or the breast, the lungs on the CT scan, you have to figure out what it is. We get biopsy, we look at tumor markers, CEA, CA19-9, all of these. And then now that we have a diagnosis, we have a molecular evaluation, and us in oncology are doing more and more, and she just gave us some even insight to whole genome sequencing. When we look at tumors, so we're looking at that genetic material from the actual cancer cells, and it helps us to derive treatment, and that's what the last category there is. The T is for treatment. So the point that I want to make with this slide is that if you skip any step as an oncologist, you failed your patient. You can diagnose, do a molecular evaluation, and treat without screening. Well, guess what? More than 80% of your lung cancer patients are going to be stage 4 if you skip the screening. They come in, 65% of them are stage 3, 4. And the survival curve for a patient with stage 3, 4 lung cancer is all the way down. Even for stage 1, it's only 65% at 5 years. Once you get to stage 2, you're down beneath 50%. And at stage 3, 4, stage 4 is doing better now because we have novel therapies. But if you skip screening, you do a bad thing. If you screen but then don't diagnose, so there's an example of a patient who came to see a pulmonologist, got a low-dose screening CT, found an abnormality, but then never went back for biopsy. And then I saw that patient last week in clinic with now a 5-centimeter tumor in lymph nodes. So now that's got a stage 3B cancer instead of a 1.4-centimeter tumor when it was initially discovered. So the diagnosis didn't happen even after the screening. If you skip the molecular evaluation, you're going to put more than 50% of your patients on the wrong therapy. Why is that? Because now we have targeted therapies in lung cancer, and in breast cancer, and in colon cancer, and in prostate cancer. And if you don't do the molecular evaluation, you don't get your patient on the proper therapy. And then if you do everything but don't treat your patient, obviously there are times when that's appropriate. Sometimes your patient's got other comorbidities and they really don't need to go on cancer therapies because the cancer therapies can be very, very aggressive. And there's not a time that I can't think of when a primary care doctor reached back out to me and said, "Are you sure, this patient probably should be on hospice?" And there's a nurse practitioner that I was working with one of my patients. She put him on hospice 3 times. I said, "Stop doing that. Stop doing that. Don't put him on hospice again." That patient had immune therapy with side effects, and those side effects can sometimes be very, very concerning. But when I got the patient on the right dose of steroids, his tumor's continuing to shrink, and clinically he's improving, so don't put him on hospice just yet. Let's have that collaboration that Dr. Ritchie mentioned to us. So back to the breast cancer. So we know about the breast cancer symptoms. I won't go into all of this. I'm not a breast cancer specialist. I'll let Dr. Vidal talk to us about this and Dr. Ritchie. But when your patient comes to you with any of these symptoms, whether it's changes in the skin, if they felt a lump, we know that we need to send them for mammography. And patients are getting their mammography. They're getting their breast cancer screening, and they're getting their diagnosis. And so the 5-year overall survival for breast cancer is more than 10 times that of lung cancer, okay? So you'll see that I'm keep bringing this back to lung cancer because these tumors, breast, colon, and prostate cancer, are our prototypes for which we should follow lung cancer screening. But are we doing that? No, we're not. We've decided that we're only going to screen smokers, remembering that that's only going to catch 80% of lung cancers. And my youngest patient with stage 4 lung cancer was 24 at diagnosis with brain metastases, and she's got a genetic alteration that's driving her tumor. And now in 2023, she has no evidence of disease for the past several years, and she's doing really well. So we really need to change our approach to lung cancer to where we're screening everybody. Do we need to screen everybody every year? No. Do we do that in colon cancer? No. Colon cancer screening is risk modified, it's risk adapted. So if you have a colonoscopy that's abnormal, then you get another colonoscopy sooner. But if you have a regular colonoscopy or everything's normal, you don't come back in 1 or 3 years. You come back in 5 or 10 years. And we need to just do the same thing with lung cancer screening. So for the mammography and these other modalities that we use to diagnose and get our patients with breast cancer onto therapy, there's mammography, the 3D mammography of breast tomosynthesis, breast ultrasound, breast MRI, also contrast enhanced digital mammography, and molecular breast imaging. So for prostate cancer, we know the PSA is very important. Patients will come in with some of these symptoms, problems urinating, maybe blood in their urine or semen, trouble getting an erection, and then we have to normalize letting our patients talk to us about these things. Sometimes patients feel a little bit shy to discuss these things. I had a patient was seeing me for lung cancer, but since he started therapy, he's noticed a difference in his erection pattern. And so he was a little bit hesitant to say it, but I tell you, his wife just was like, look, we're gonna talk about this right now. Like, we gotta talk about this. And she put it out there, and then, it's very important. And so that we make our patients feel comfortable and that they don't feel, uncomfortable discussing these things. Other symptoms, pain in the hips, the back, the spine, these are actually very advanced prostate cancer symptoms where you have bony metastases. So hopefully our patients aren't being seen at this state, but we know as a matter of fact that that's happening in our primary care clinics where your patient comes to you with some of these symptoms. And like it was just pointed out, sometimes we hide our sicknesses, not only from our family members coming behind us after we've been treated, but during the actual illness, we don't discuss it for sometimes religious reasons. And we've had our patients in our communities, just kind of not want to, claim is the word, not claim their illness. And I tell my patients, it's claiming you. So we got to talk about it. Patients also come in with weakness or numbness in their legs or feet. Bowel or bladder dysfunction. All of these are signs, again, of late prostate cancer symptoms. But hopefully is it going to change? There we go. With the prostate cancer screening recommendations that we're following, we're catching patients earlier, and we've heard about the different genetic risks that can cause prostate cancer. So we screen those patients earlier, age 40 for men who have a higher risk, 45 for a slightly lower risk, and then age 50 is the regular age to start screening. And we do that with PSA, so a blood test, and then also the digital rectal exam, which is less sensitive than PSA testing. And we can see here factors that cause PSA to go up and also factors that can cause lowering of the PSA. Some medications, some herbal things that patients may be doing can lower PSA, where older age, prostatitis, ejaculation, also riding a bicycle and other urologic procedures can cause elevations of the PSA, and then also certain medications. So PSA can be nonspecific, but it is more sensitive than a digital rectal exam. And we can detect prostate cancer that's not shedding into the circulation if we use a digital rectal exam. So if we see small cell of lung cancer, but there's also a small cell prostate. And PSA doesn't go up in small cell of the prostate. So sometimes that patient has clinical symptoms, but you can't find an elevation in the PSA. You still need to perform that digital rectal exam so that you can find that prostatic tumor. And we use that when suspicion is high despite normal limits of the PSA. So look at the 5-year survival rates from prostate cancer. Is lung cancer there? Not even, almost. I wish, but we're going to get there. So you see back in 1975, 1977, we saw prostate and testicular cancer at 68 and 83% 5-year overall survival. Well, around 95 or 97, both of them peaked at over 90%, and in 2018, it's still around the same thing, 97, 95%. So, I mean, you really can't go much higher than that, but lung cancer is not even where we were in 1975 with prostate cancer, colon cancer, and breast cancer. And I will say to you that lung cancer is killing more patients than what prostate, colon, and breast combined. So I say to everybody whenever I give a talk on lung cancer, this is the most important talk of the night. I want y'all to remember that. Because when you go back to your clinic, your patient had secondhand smoke exposure, or either they smoked or they worked in an occupation that gave them risk factors for developing lung cancer. And right now, we're not screening those patients. We're only screening smokers. And so we'll talk about that at the very end. This doesn't, no, there we go. So colon cancer screening, just briefly, because the patients are getting their colon cancer screens for the most part. Obviously, there are patients who are coming in late and who aren't doing what they need to do. But when we look at lung cancer, colon cancer is doing much better. So colonoscopy, virtual colonoscopy, the fecal occult blood testing, probe-based confocal laser endomicroscopy. Is anybody doing that? No, I haven't. I have never heard of that actually until I studied this. So I don't think that's something that's happening in clinical practice much. I hate that the gastroenterologist left, but I don't treat colon cancer, but I haven't seen anybody do the PCLE. So the symptoms, diarrhea or constipation, changes in the stool shape, size, and frequency, discomfort, abdominal discomfort, cramping in the lower abdomen, bloating. Some of these things can be very vague, and I've had patients come to me and say, well, I thought it was a bad sandwich that I ate, and so I started having these symptoms. And, you know, to a patient, they find something that they can relate to, and they may or may not be considering that these symptoms can be symptoms of a cancer, especially in our younger patients. And so we've heard about patients in there, I think there was a molecular tumor board today, a 37-year-old patient with metastatic colon cancer. So that patient, when he started to develop symptoms, clearly was not thinking that he had colon cancer, let alone metastatic colon cancer. But these things can happen. So in our primary care, and Ms. Sharon made a really good point tonight when she said that we need to start encouraging our patients to come in when they're well. That was really, really life-changing for me. It's about changing the culture. And instead of waiting, and we're going to have to start here and make sure we roll it out, because the culture really is to come in with symptoms, and we don't do well care. And it starts at birth. I don't know if there are any neonatologists here, but I did do some work in the OBGYN clinic when I was in undergrad and before I even went to medical school. And there was a large high-risk population here in Memphis, and we have a high rates of infant mortality and premature birth. And with that, even at birth, these patients aren't starting with well care. They're starting with sick care, and we are just reacting to whatever is happening to them. And that's what our culture is right now. We react instead of being proactive. And so why wait after Dr. Gaylor talked to us about colonoscopy tonight? Why wait until 45? I'm not there yet, but you know, what if and I had to make that point because my classmate told everybody that I was 40. We went to college together. And she sat up there and said, I'm in my 40s. Are you telling everybody? Shh, it's a secret, okay? Yeah, so no, we are in our 40s, but I'm not quite 45, so am I gonna wait on my colonoscopy? I tell y'all what, I had abdominal pain in 2016. It was in my fellowship. And I went and I got a CT scan of my belly. And I was like, get my lungs while you're doing it. So I got mine, okay? You can get yours if you want to, but I got my lungs scanned already. So getting on to lung cancer in my last minute and a half, really quickly though. Look, it's number one. It's the number one or top cause of cancer-related death in the U.S. 60% 5-year survival for early stage non-small cell lung cancer down there in your bottom left. 60% for early stage. 80% caused by smoking. That means 20% not. That means 1 in 5 not. And then at the top, you can see almost 230,000 people died of lung cancer in this year. The age for lung cancer screening is 50 to 80. I told y'all my dad, back then it was 55. As a matter of fact, when my dad was diagnosed with lung cancer, there was no screening at all. But now it's 50 to 80, and my youngest patient that's a smoker was 45 when he was diagnosed, and my patient who's 24 when she was diagnosed was a never smoker with an oncogene driver. They have to be current smokers or quit within the past 15 years and have a 20-pack year smoking history. It's a low-dose CT. I put the picture there, and the reason is because you can see he still got his clothes on. So the CT scan takes like 2 minutes. You don't have to take off any clothes. You don't have to have a camera, inserted into orifices. You don't have to do a prep or any of those kind of medical preparations. You just come in, there's no contrast. It takes 2 minutes, and the patient's up and off the table, and you may have saved a life. So this is just a quick case. I had a 58-year-old female. She was a smoker, and she was in for her initial evaluation with me. She actually already had a diagnosis of lung cancer back in 2017. She was seen by a different oncologist, but then her insurance changed, and she had to come to me for her continued surveillance. So I see her in the clinic. She came in. She had her CT scan, and you can see there, NED, no evidence of disease. So we started talking, and this is a case that I mentioned earlier, and I asked her, so what about your husband? Does he smoke? She goes, oh, yeah, he's a heavy smoker. He's been smoking for at least 45 years. He feels fine, works full-time, no complaints. And so I told her, bring him in to see me. And he came in to see me on the next Friday. I was seeing her on the Friday. The next Friday, she brought him in, and he had a low-dose CT scan last Friday. And there it is. On the right, on your left, you can see his CT scan. And then the PET CT scan, which was just performed today, confirms that he actually has an avid lesion in his left upper lobe. And he went to see a surgeon, and that surgeon is planning to take him to the OR. We're just going to wedge this out. It's only 1.4 centimeters. He doesn't need a biopsy. He's high risk for having lung cancer. And he doesn't need a lobectomy. So he's already got some emphysema kind of changes on his CT scan, you can see there. And for a tumor less than 2 centimeters, you don't have to take out the whole lobe. Just wedge out that one portion, and he can continue on now with a stage 1A2 lung cancer as opposed to stage 4. It's in the middle of his lung. Before it got to his bronchus or his airway, when he would actually develop cough or some symptoms, it would have been stage 4. By the time the tumor is big enough from that position, it's going to have metastatic disease at least to lymph nodes. So he would have at least been a stage 3 diagnosis if he waited on symptoms. So it's just a matter of word of mouth. I just asked her, what's up with your husband? And she brought him in to see me, and now hopefully we've changed his kind of path. So cancer screening and detection is obviously important. Breast, prostate, and colon cancer screening are effective. We know that. We see improvements in outcome compared to lung cancer, where screening remains underutilized. Dr. Ritchie actually gave a talk in 2021 where we looked at the utilization of lung cancer screening, like coming out of the COVID pandemic and where things were starting to light up again. Even now, less than 6% of eligible patients for lung cancer screening are actually being screened. So we have a lot of work to do to try to roll this out, at least to the eligible patients. But my goal is to hopefully within the next 5 to 10 years make it a general screen where we do risk-adapted or risk-modified screening for lung cancer. Campaigns to encourage the screening are essential, and the destigmatization of smokers. And somebody talked about targeting already tonight. When we only screen smokers, they feel targeted, and then they don't want to come out. That patient's husband, he came out, but he didn't do so happily, and luckily he did. So it's necessary to keep moving these efforts forward, and I think it's not working, but I'm pretty sure that's the end. There you go.
Thank you, Dr. Porter. We're still a little behind, so I'm going to jump right into